Good evening, everyone, and a very, very warm welcome to this session today. And thank you so much to everyone for being on time. And we are also starting on time. It gives me immense pleasure to see Dr. Michael Ramsay once again. Uh, can't stop talking about you to so many people. Say, do you know the creator of Ramsay scale? We get to meet him, we get to hear him. This like fantastic feeling for all of us. So, without much delay, first of all, let me invite our current ANEI's National President, Captain Ajita Nair, to come in and give a welcome address. A very warm welcome to Dr. Michael. Following that, I would give a short report on the fellowship program so far. Over to you, Ajita.
Thank you, Tankam. Good evening to everybody and good morning to Dr. Michael. And it is our immense pleasure to welcome you, sir. And as always, and it has been, unbelievable that it's been 2 years that we had been running this fellowship program on patient safety with all your support. And we are very, very happy to tell you that this has become our flagship program and most popular program. So much so that this year we really had difficulty in choosing the people. First year it was very easy because there were few applicants, and second year was little more tough. And we just had our third year of initiation of it, and we'll be meeting them today. And it was really, really tough for us to choose the people because we have limited seats, and it was really tough. So it is picking up the momentum, and we are reaching length and breadth of our country at least, and we are very happy with the progress so far, and the progress in which all of these people have made as well. And the message of patient safety is beginning to reach thousands of patients and healthcare workers in our country, and we are very, very happy to tell you that. And so meaningful program of ANEI. And I would like to welcome you, sir, for this program, and also the fellows of cohort 1 and cohort 2, as well as cohort 3. We are going to start this day. And also we have opened this invitation for this meeting to many other people too. So there are a lot of people logging in and to witness this program, and it's our pleasure to reach out to everybody. And thank you so much. And this has been recorded, and it will go onto our website as well, where many, many more people will be listening to us and taking the message of patient safety. It's very, very imperative to reach out to every healthcare worker with the message of patient safety. It is not intentionally that something goes wrong in our healthcare system, and we have to put the system in place so that error proofing can be done, so that our patients as well as the healthcare workers are safe in our hands when they come to us for seeking healthcare. So once again, thank you so much, sir, for coming, and a hearty welcome to one and all. Thank you. Thank you so much.
Thank you. Thank you, Captain Ajita, for that. Sir, just give me the permission to share with you the very short report on what happened from 2021. Can I do that? Sir, I think you're muted. We are not able to hear you.
Oh, no,
Now it's okay.
Yeah, now we are okay. Now we are okay. So I'll just bring in my, the slides that I had to show our cohorts. So I hope you can see my slide.
You can.
Slide? Yeah.
Yes.
Yes. So that is our cohort 1. We started in 2021. And this happened through Patient Safety Movement Foundation because I stumbled upon the website of PSMF, and then I volunteered myself to be the patient safety ambassador. And then from there I wrote to PSMF, and then Olivia got in touch, and I spent some time being in the education committee of PSMF. So I used to go for meetings in the middle of the night and, contributed to at least medication safety part. There was some group that we were working. I was lucky to be working with eminent patient safety champions of your country and from across the world, some of them. Dr. Donna Prosser was also instrumental. This happened when I heard about the PSMF fellowship program that you are giving across the world. So mostly I saw the fellows are mostly from the government, very senior people. So I started talking to Donna to see that whether we can bring something similar for nurses in India. And she said that's a very novel idea, but she did support and Olivia did support. And then that's how we got our first cohort. So the first cohort, I must be grateful to them because they kind of laid the foundation for what is now is a structured program. It is not a open program. They all have to learn about WHO patient safety curriculum. So that effort was done by cohort 1. And they were also instrumental in doing a couple of studies and presenting it around medication safety and for nurses. And they also created PDF on 100 medications, easy reference for nurses, which is actually uploaded on our website as well. So I'm very proud of the cohort 1, and they are completing 2 years, and they are the ones who are going to get the certificate. Some of them have volunteered to stay back to help with mentoring the new group. So they're not going away, though they will be getting the certificate today. So that is our cohort 1. Miss Anita Jayakumar, Dr. Vijaya Tonkam, Miss Ishita, Miss Glory, Miss Priyanka, Miss Shiny, and the only gentleman in the group, that is Mr. Vinod Kumar. So all of them came with the different capabilities and competencies, and we were able to put it all together and bring in some results for the better of nurses and patients in our country. So that's our cohort 2, whom we inducted last year. That is Miss Kavita, Miss Krishna, Miss Lata, Miss Purba, Miss Ramya, Miss Dr. Rosaline, and Miss Saujanya. So they are the ones who have gone through the WHO patient safety curriculum. They did some sessions, and after that, they have done a quality improvement project. And that is what they are going to present today. To ensure that we are on time, we have got them all recorded. So they're all within, the time limit. And so we will be presenting that, and post that, of course, we'll ask you for your advice. Proudly we present the third cohort, which Ajita already mentioned how difficult it was to shortlist. So there are 9 of them. So we couldn't stop at 7 or 8. So we decided 9. We are getting a little bit more ambitious because the program is pretty much getting, very clear what needs to be done. So I think maybe one mentor may take 2 on board to help them. And as I was mentioning to you earlier, we are definitely going to focus on the evidence-based practice documents that is available with Patient Safety Movement Foundation. So that is going to be our focus. That's my commitment. And I still will be holding on to this program to mentor and guide all of them. And someday one of them would probably take it over from me, but patient safety never goes away. When I look at you, I don't want to give up anytime. So that will be too soon to do anything other than, fighting for patient safety. So this is what we have done, sir. And thank you once again for blessing this program in India. It means a lot for us. And it's early morning in Texas. And once again, thank you, sir. And over to you. We are eagerly waiting to hear from you.
Thank you so much. And Captain Nair, thank you. And thank you all. I mean, first of all, it's a great honor to be here, but I am so excited by the graduation of the frontline staff that you are. And I gave a talk one time in Abu Dhabi, and the nurse stood up in the back and said, "What we need is a patient safety army." Well, you are that. You are the front line of a patient safety army, because you're going to go out there. Unfortunately, patient safety is still not in most curricula. And so you're going to go out there and be the leaders, the front line, to teach healthcare workers about patient safety. We have enormous amount of healthcare workers, dynamic workforce. They do so much, and none of them wants to hurt a patient. It's the situation that they're in, the processes they have to go through. Plus, they're not flying an airplane. They're not dealing with a nuclear plant. They're dealing with a very organism, a human being. And so one small thing can hurt that human being. And so we have to go in there, you have to go in there as the front line and educate and teach and put practices in place, evidence-based practices that will work and help those healthcare workers from harming patients, because none of them want to do it at all. This month is World Patient Safety Month. World Patient Safety Day was September the 17th. And I'm so glad to see that Dr. Neelam Dhingra is going to be on your program tomorrow morning. She is phenomenal. She has led the World Health Organization over the last 3-4 years on patient safety. All the work you see coming out of WHO is Dr. Neelam Dhingra. She is the powerhouse behind it, but it's making a difference around the world. I'm so honored to listen to her tomorrow morning when she comes on. But back to you, this is going to be an exciting day to hear what you have done, those of that you have completed, and those of what you're about to do. I'm really looking forward to it. I think it's going to be great. This also is Sepsis Awareness Month. Every month seems to have something. Well, this one's sepsis awareness. And you may not know, but sepsis affects an estimated 49 million people around the world each year, and more than 20 million children under the age of 5. And sepsis kills 11 million people a year. Now, that's not all in hospital. A lot of that sepsis occurs out of hospital, but hospital-acquired infections occur regularly. That's a main reason we get complications of patients in hospitals. And so I think you need to really put forward some simple things as you go out there, like hand washing. Don't let people skip that basic thing of hand washing before they touch another patient, because as Dr. Dhingra will tell you, this is the year of the patient, the engagement of the patient. The patient is number one. That's what we're all working for, is to look after the patient. So when you go into a room and there's a patient there, who's the most important person in the room? It's the patient. I know you all know that, but just to emphasize it. So I'm looking forward to the rest of this evening and what you all have to say, and congratulate those who are getting certificates, and congratulate you all on the program. This is terrific. Thank you so much.
Thank you, Dr. Michael. So shall we do the project recordings one by one, and then you can opine on them. Once we finish all of them, we have 2, 4, 6, 1, 2, 3, 5, 6. 6 recordings are there. You tell me, sir, how do you want to take it? You want to do one, pause, or we will just play one after the other?
Maybe we can do one at a time, and I just make a few comments
sure.
after each one.
Okay.
While we switch to the next one.
Yeah. So first we have is Miss Kavita Jayaprakash from the cohort 1 presenting. Just give me a moment. I will just get the file and is that visible to all? Okay, great.
Pleasant evening to one and all gathered here. Myself, Kavita Jayaprakash, working as a charge nurse in Communicable Disease Center, Hamad Medical Corporation, Qatar. I would like to thank Thankam ma'am for her constant motivation and support. Being a captain of our ANEI Fellowship program, it's a great pride for us, ma'am. Thanks for this wonderful opportunity to be a part of this program. My heartfelt thanks to Dr. Professor Michael Ramsay for being with us here today. It's a honor, sir, to present all our quality improvement projects in your presence. Thank you so much for your valuable presence. My heartfelt thanks to all my Cohort 1 and Cohort 2 team members for your constant motivation. Last but not the least, to my principal, Dr. Lata Venkatesan ma'am, and my clinical guru, Professor Jyotiklara G. Michael, for their constant support in grooming myself throughout my nursing career. I would like to share my quality improvement project here with you. It's my privilege to share my quality improvement project. Before that, I would like to thank my mentor, Dr. Vijaya Thankam ma'am. Thanks a lot for your constant motivation and support, ma'am. Without you, it won't be possible. Any new place or any new faces or unfamiliar services, it always leads to chaos, especially a sense of fear among our patients. Do you think if you are admitted in hospital, how do you feel? You feel you are in the safe hands? For that, we need to gain the confidence of the patient. How it's possible? Of course, it's possible with proper patient orientation. That may be a chance. If there is any misrelay of basic communication by the clinical caretaker, it may lead to unnecessary second thoughts for the patient, and we may lose the hope of the patient. Therefore, we thought patient orientation fosters a sense of confidence and empowerment for the patient throughout their journey of recovery. The main background of this project is ours is a huge healthcare system which comprises of patients who are admitted with communicable diseases. They may be present inside a single isolated room throughout their course of stay. That time we found out there are a lot of lacunae and mishaps happen, especially in terms of communicating with the patients. And patients do have a lot of queries, and being isolated in the room, they may have thinking about how many days do I need to be in isolation, whether my family members can come and meet me, how I can relate, communicate with myself with the outside, what is happening outside. All these things will come in queue. So if they want to communicate with the healthcare professionals, how they need to communicate, how to use the call bell, how to access the facilities which is available inside the amenities, like that, it was going endless. So we thought of initiating this project. These are all my project team members. My project is on ensuring patient safety, also patient orientation, feeling at ease. Why we need to start this project? We feel that there is a big gap find out between the transmitting of information from the healthcare professional to the patient side. Our customers are the patients. We need to take care of them well in a structured manner so that they feel the entire stay of hospital stay will be a pleasantful experience. So we produce the standardized framework so that we can orient all the needed information to the patient upon admission, which helps them, which supports them, the better, safe environment to them, thereby orientation to them to the new environment, how to handle the call bells, how to operate the Wi-Fi access, TV handling, call bell usage along with side rails handling, how they can able to get their sharing of information through whiteboard communication. All these things can be set in place. But we found there is a gap because of awareness, especially in terms of communicating to the patients, because of language barrier, lack of time, and sometimes patient may also feel tired due to their illness. And also being in an isolated facility, there is a less chance of communication between the healthcare providers to the patients. We thought it has to be taken into consideration, and we initiated this project. We found out this cause and effect diagram. In that, we found there is a procedure delay, structure delay, and also in terms of patients and training activities, we found a lot of reasons, how many whys, so that we can able to find out what can we do the best for the patient, which leads from patient dissatisfaction to the patient satisfaction. Our main objective is to ensure 100% of all our patients oriented for patient-centered care activities, especially in terms of patient orientation upon 24 hours of admission, and improve the nurses' compliance in documentation by 50%, and also improve the patient awareness with providing proper patient orientation by the end of August 2023. This is our process map. Once the patient got admitted, patient will be escorted to the unit through the nursing aides or the assigned nurse from the particular unit. Assessment will be done by the assigned ORNs. They will give proper orientation to the patient through brochures and booklets, and the clarification has been done. After completion of all these processes, the process will be documented in the electronic medical record, which you call it as CERN. And all these process has been monitored by our champions, and the audit has been done with the patient interview. The PDCA of our patient orientation goes by this way of structured mapping of the patient orientation, formulation of patient orientation questionnaires through the interview-based techniques. Followed by that, we do document verification done by our champions in the CERN, our electronic medical records, compilation of all the data analysis, and with that, we can able to project with our patient satisfaction questionnaire and comprising that into a graphical representation. Since March 2023, I introduced this video-based method of education in all patient rooms through USB, connected with the TV channel. Patients can easily access the patient orientation without any mishaps or gaps through the complete video programs. This made us ease our job to a great extent, and patients also feel satisfied. At the same time, nurses also feels much satisfied because it consumes very less time of communicating all these information to the patient. And also the patient can refer to this video any number of times and they can get clarified. The methodology we adopted is fishbone analysis, Ishikawa diagram. The audit tool methodologies, we do have callback techniques applied during the COVID time and getting the feedbacks. We do have weekly hurdles and also the interview checklist of patient orientation. Patient orientation monitoring tool, this is the one we used for our interview purpose. After the documentation, the nurses has to sign in the electronic medical record. We call it a CERN. The orientation process goes through from welcoming the patient, providing the orientation to the patient, clarify the doubts and allow them to question ourselves, and also document all these processes in the initial assessment column. The brochures we used for the patients are displayed here for your reference. We found after introduction of all these things, especially in the March 2023 introduction of the video-based awareness program, especially on patient orientation, we found a tremendous improvement from 48% to 91% of awareness among patients, especially on patient orientation. Also, in terms of compliance to patient orientation, nurses found adequate time. They don't need to rush upon their admission process, and they found a lot of me time with the patient, especially in terms of bedside care activities other than documentation and other allied works. So they also feel satisfied they can able to give 99% of compliance to patient orientation documentation. We found a tremendous change and improvement through our continuous education, remodeling of the restructuring of our process, and also we do have a better, proper bedside handoff process institute. So thereby we can able to transmit the information from one shift to another shift without fail. There is a continuity of process, and also the whiteboard documentation will help us to find out the preference of the patient, where we can able to merge the gap. Especially in terms of COVID, in all the three phases, we do have some difficulties, but we overcome the difficulties with restructuring of our project. And also, we do have callback systems by telephonic interviews conducted among the patients. To summarize my project, the awareness and satisfaction was increased among the patient. Staff satisfaction also improved among the patients with the proper introduction of video-based techniques. We also incorporated balanced workload, debriefing of times, train the trainer programs, champions identified in each floors, quarterly meetings, voicing out the issues, what we are facing at the bedside, and also patients nominated the nurses who did wonderful care at the bedside to them during their length of stay, which she called as Najim Award. Appreciation for the patients. Moving on to the way forward, we thought we can introduce the video-based techniques in 3 different languages with subtitles, and also providing booklet brochures, conducting spot audits, and also team meetings, and escalating to the next level, interdisciplinary rounds, especially in weekdays. Tuesday, we opted a specific day for that, and also barcode scanners, which can able to help paperless system. They can refer everything in the barcode scanners. These are my references. And thank you so much for your patience listening. Patient orientation feels patients should be more comfortable during the length of time. Thanks to PCC, thanks to CDC for giving me this opportunity to conduct this project. And together we can achieve everything. Touching the life of the patient is the ultimate goal for each and every nurses. Thank you, team, for your patience listening. Thank you, everyone.
Thank you. That was an excellent project. It really was. You know, we did some terrible things during COVID in the United States, and that was we didn't allow families in to see patients. And the elderly patients, particularly, they got delirious, they got dementia, acceleration, and it was really very cruel. And I don't know why we didn't think of video. I mean, everybody's got a video now. It's on your phone, you know. I mean, it's we could have communicated so much better. And what you did, I think, was terrific, because now the nurse is readily in contact. You've got your number, you've got how the patient knows how to communicate with you. That makes it so much more personable. I think we didn't make the patient number one during COVID, and we should have. You obviously did in your hospital, and congratulations. I think that's great.
Thank you. Thank you so much, Dr. Ramsay. Thank you. Kavita, you can unmute and say thank you. You were
Thank you so much, sir. It's an honor for me to hear great words for me. It's a great because of our teamwork and leadership support for us. It was supported by them. So without them, nothing is possible. That's why I told together we can achieve more. As you said,
Right.
we are all the patient soldiers, safety soldiers. Thank you, sir.
You're the patient safety army. Absolutely.
She is actually working in Hamad Medical Corporation, Doha, Qatar.
Really? Oh, well.
Project there. She did the project there, yeah. So she joined when she was here, and then by the time the project came, she was in Doha already. So she did the project there. So it has crossed the borders of India.
Well done.
Thank you. Thank you, sir. And we will just move on to our next presentation. That is Lata US. Just give me 1 second. I'll just share. Okay, I hope you can see my screen. Yes. Hello, can someone just...
Yes, we can.
Okay.
Yes, ma'am, we can see.
A pleasant good evening to all. Special good evening to Dr. Michael Ramsay, Ms. Tankam Gomez, and leaders of ANEI. Myself, Lata, ANEI Patient Safety Fellow Cohort 2. I'm honored to present my quality improvement project as a part of fellowship program. Before presenting my quality improvement project, I would like to say thanks to Dr. Michael Ramsay, President Patient Safety Foundation, USA, for giving me an opportunity to be a part of patient safety activities. Then next, I would like to convey my thanks to Ms. Tankam Gomez, who was the backbone of our fellowship program, and then for your valuable guidance throughout our journey. And then I'm very grateful to Dr. Jadhav Sonali Tarachan, who has initiated me to enroll for this fellowship program. And then at last, I would like to convey my regards to Cohort 1, Mr. Vinod Kumar, Ms. Ishita Chand, and Ms. Glory Emmanuel for their timely help. Now I am going to present my quality improvement project. Title of Title of my project is Safe Medication Administration. As we know that medication error are common cause of adverse healthcare incident that has more impact on quality of care into the patient. A medication error may account up to 1/3 of medical error in a hospital, and then all medication error do not cause mortality into the patient, but they will cause severe morbidity and increase hospital stay and then hospital expenses for the patient. Despite of continuous audit and supervision by senior nursing officers on safe administration medication at our hospital, medication error was increased up to 12.5% over the first 6 months from January 2023 to June 2023. Some of the medication errors result into serious morbidity and increased hospital stay. So this project has been taken up to reduce the medication error from 12.5% to less than 5%. Aim of this project is reduce medication error from 12.5% to less than 5%. Objectives of this project are to determine the incidence of medication administration error and find out the gaps at acute medical ward. Second objective is to plan intervention to prevent medication error at acute medical ward. Third objective is to evaluate effect of intervention packages to reduce incidence of medication administration error. This project was done at Ramsay Medical College Hospital, Bangalore. It was 800-bedded multi-specialty hospital. Champion of this project is Dr. Saik Muhammad Aslam, HOD of Medicine Department. Project leader is Lata US, ANEI Patient Safety Fellow Cohort 2. Mentors are Mrs. Glory Manuel, Mrs. Ishita Chan. Team members of this project were Dr. Prasanna Kumar, clinical pharmacist, Mrs. Lima Matthew, nursing superintendent, and then Mrs. Sunita A, quality nurse, Mrs. Vanishi, in charge of acute medical ward. This slide shows that overall medication errors were occurred during month of June and July 2023. It shows that there was a more increased incidence of transcription error and indenting error, that is 25% in each, and then these errors were linked to medication administration errors. Then this table shows that percentage of medication error, the medication error occurred in the hospital. It has been calculated by using denominator and numerator formula given by WHO Patient Safety Movement Foundation. In this chart, table shows that there was a medication error led by transcription error, and then so this project has been taken up in acute medical ward because there was a more administration error was occurred in acute medical ward in the month of June and July. There was June month, there was 2 occurrences out of 19 opportunities, that is 10.5%. And July month, there was only 1 occurrence, but out of 5 opportunities, that is 20%. And then we have done root cause analysis for this errors in acute medical ward. We found that some of the root causes for this medication error. First one is process. There is no cross-checking of drugs by a nurse and writing prescription in trade name and sentence form. And then when you are looking into environment, this is very busy work area. Then there is an abrupt rise in patient admission rate. And then when looking into people, that nurses, there was lack of knowledge in the among novice nurses regarding generic name, action of drug, and then rights of medication administration. And then we found that some of the negligence, that is lack of accountability among novice nurses regarding the rights of medication administration. When you're looking into equipment, there was lack of updation in HIMS system during indenting, and there was no common drug chart display in the acute medical ward. So based on this root causes, we have started our PDCA cycle 1 in acute medical ward. So we have carried out the audit and RCA to find out medication administration errors and their root causes, and then we have planned the intervention. The following intervention were planned, that is writing prescription in generic name with capital letter, cross-checking of medication before administration by a nurse, training session on generic name and action of common drug. And then so there was the increased incidence of transcription and then indenting error error in that acute medical ward, and then it led to medication administration error. So we have taken up intervention 1 as a PDSA cycle 1, that is writing prescription in generic name with capital letter. We have conducted meeting with HOD of general medicine and developed the protocol on writing prescription in generic name with capital letter. Then informed all the doctors on protocol and initiated the process. After initiation of this process, 2 weeks we have initiated this process, and then we have given 2 weeks of cooling period. Then we have done post auditing the file. Then we found that there was a major reduction in medication error that was reduced to 6%. This is the timeline of my quality improvement project. Pre-auditing we are done between June and July month, and then we have discussed with the team members, and then we have planned some intervention in the month of July, and then PDCA cycle 1 was initiated in month of July 24th to August 5th, that is 2 weeks. After 2 weeks, we have given cooling period of 2 weeks, that is between August 7th to August 19th. Then we have done post auditing of the files to find out the medication error in between August 21st to August 25th. So based on this post auditing, we found that there was a major changes and an improvement in safe medication administration PDSA cycle. In the month of June and July, we found that total administration error was 3 out of 24 opportunities, that is 12.5% in acute medical ward. But after one PDCA cycle, that is in the month of August 2023, there was only one administration error occurrence out of 15 opportunities, that was 6.6%. This is comparison of pre and post intervention quality improvement project. When we started pre-intervention phase, that is in the month of June, where the medication error was 10.5%, and then we continued auditing till the July, and then we have initiated our intervention, that is intervention 1, writing the prescription in generic name with capital letter, where the medication error was 20%, and then we have initiated that cycle 1, and then we have initiated that cycle 1 for 2 weeks, and then we are given 2 weeks of cooling period, and then we are done post auditing in the month of August, and then we have found out that there was a major reduction in medication error from 20% to 6.6% at acute medical ward. Though by seeing this PDSA cycle 1, and then we have taken initiation to move forward to PDSA cycle 2, that is cross-checking of medication before administration by a nurse, and then we have conducted training session on cross-checking process among the nurses at acute medical ward between August 28 to September 8. All nurses were instructed to cross-check the medication before administration, and then identified team members will conducted single blind observation to confirm the cross-checking process in the between September 11 to September 22, and then post auditing of the files is pending. We are going to do that post auditing from the month of October 9 to October 21st. Then from way forward, the PDC cycle 1 has shown good impact on safe medication administration with reduction of medication administration error from 12.5% to 6.6%. So management has taken initiative to implement same process in other wards of hospital to prevent medication error. Now we are in the process of PDSA cycle 2 to reduce medication error by cross-checking the process of medication before administration by a nurse. And then we are planning for PDSA cycle 3 also, that is training the nurses on generic name and action of common drugs used in acute medical ward. Then we have referred the action for our quality improvements. We have done references, that is actionable evidence-based practices, Patient Safety Movement Foundation. We have taken major points from the PSMF references, and then we have looked into other websites also for taking the references. Thank you.
Well, congratulations. You made a difference. That's the most important thing. The study worked, which is great. It's a problem, though. Medication errors are still, they were the WHO theme last year, how to prevent medication errors. they still occur. And unfortunately, in the area specialty that I was in, I ran an anesthesia department. We have look-alike ampules. One ampule with a blue top looks identical to another ampule with a blue top. One's adrenaline, epinephrine, and one's atropine. One will speed your heart rate up. One will probably kill you. And so medication errors, we do have to have some kind of check system. You put in a manual check system where another person checks. That's great if you've got a second person, but often you have to give medications in emergency, urgent situation. Is there a check system there? And that's where I think part of our patient safety army has to be the med tech companies. They've got to come up with cheap scanners that can help us scan the meds and make sure it's the right patient, right drug. I think some tools could help us when humans are busy and they don't necessarily have the right time to make the difference that's needed. But congratulations, you showed an improvement, and that's what counts.
Thank you, Dr. Michael. And some of the hospitals in India are going for scanners, and not many. Hopefully, more will follow suit, I guess. And you are very right. We cannot be totally human dependent technology. We need to get their help. Yeah. Great. Thank you so much, Lata. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you.
We will go on to the next one. 1 second. Next one is by Ms. Purba. All of you can see the screen?
Yes, ma'am.
Yes.
Hello everyone. A very good evening to all the dignitaries present over here. I am Purba Das, a member of ANEI Patient Safety Fellowship Program 2022 to 23. I would like to extend my sincere gratitude to ANEI and Patient Safety Movement Foundation for giving me the opportunity to be a part of this platform and sharing my project with you all. Let me share my screen. So my project is on modified early warning score. And here is the team members. The project was conducted in Fortis Hospital, Anandapur, Kolkata. And the project leader, that's me, conducted the whole under the guidance of Ms. Priyanka Sirsat and Mr. Vinod Kumar, member of APSF, and Ms. Dolly Vishwas, the Chief Nursing Officer of Fortis Hospital, Anandapur. Modified early warning score have been developed to facilitate early detection of deterioration by categorizing the patient on the basis of scoring system against respiratory rate, heart rate, systolic blood pressure, oxygen saturation, temperature, along with hourly urine output, loss of level of consciousness, and pain. And it is seen that the number of incidents of cardiac arrest are increasing comparatively. And patients with adverse events during hospitalization often display the clinical decline for several hours before the event observed by the medical personnel. And sometimes the clinician's inappropriate decision as well as non-critical care nurses' inconsistent recognition and response to patient deterioration lead to an increase the length of hospital stay, along with increase the rate of morbidity and mortality rate. Here the line diagram shows the occurrence of code blue and escalation of early warning score in between the month of August 2022 and February 23. As the project was initiated in the month of August 2022, so from that month the data is captured. And it is seen that the number of code blue in comparison with escalation of early warning score is more, as we expect always that the deterioration of patient will be always very less. We will expect the quality care. So we will expect that the number of code blue will be either 0 or maximum not more than 1. So a quality improvement project was initiated on timely identification of early warning signs and interventions on implementing the rapid response team to increase the rate of survival among adult patients in Fortis Hospital, Anandapur, with the aim of reducing the number of incidents of code blue. The objectives of the project were to implement the rapid response team for early intervention, to identify the factors interfering in increasing the early warning score, to improve the knowledge and skill of staff nurses in early identification of the early warning score, and to secure the patient safety and quality nursing care. So to accomplish the goal, the PDSA model was adopted, where it was planned to form a team, develop a point prevalence audit checklist for audit, and identifying the gaps in between, for which RCA was necessary to initiate, and training and awareness of the staff is very much necessary to fill up those gaps. And few initiatives were taken, like forming the rapid response team and enlisting the rapid response kit in every ward area. Here's the root cause analysis, and the root cause analysis was performed by using the Ishikawa model, where we can see that it was found that the absence of clinician in the department and sometimes the clinician's decision were responsible. Not only that, but because of the busy schedule and number of more allocation of the nurses and number of patients diagnostic evaluation and repeated doctors round make the nurses distracted from their job and sometimes causes in gap in the documentation. And because of their tiredness, the staffs are attending a very less number of training. And not only that, but also the patient's lack of knowledge regarding the presence of their comorbidities that tends to early deterioration of patient's condition. Here are the interventions of those initiatives, like continuous nursing education in classroom as well as the bedside. In classroom, whenever we are conducting the nursing education, we have conducted the pre and post assessment of the to assess the improvement of their knowledge. And here is one sample of the knowledge assessment test. Another is point prevalence audit was also conducted to find out the effectiveness of the training. To assess the knowledge of the nurses, total 125 nurses were randomly selected in the ward area. Pre and post test was conducted for everyone, and the pie diagram shows there was a mean knowledge, significant improvement of mean knowledge among the nurses, that is 59 to 89%. Another initiative, that is formation of the rapid response team, and the contact number was 8787. This was designated to reach the RRT team, as in the morning time all the supervisors are present, so especially evening and night time it was very necessary, and the evening and night supervisors were empowered to take proper decision against the patient condition. And rapid response kit was arranged in every ward area along with a checklist to make the staff understood that the purpose of the item 2. And here is the EWS point prevalence audit checklist that was formed and initiated in month of July 23, that contains total 11 questions along with 12 options, that is any other findings we can found that can cause the early warning increase in early warning score we can mention there. Midweek of every month is selected for the audit, and data to be collected in inpatient ward area, and accordingly all the wards were divided among all the auditors, and total sample size was 60. And the bar diagram shows the compliance rate of initiating this audit, this point prevalence audit. The audit was initiated in month of July, and though the benchmark is 100% and we are a little far from the benchmark, but we can see there is a significant improvement from the month of July till August. And this is a continuous process, and it is conducted in every month. So here is the occurrence of code blue versus activating the rapid response team. As the project was initiated in month of August 2022, so the 1 year data is displayed over here. The formation of our rapid response team was in month of February, from which onward we can see there is a marked improvement in number of activating the rapid response team and a significant reduction in occurrence of code blue. So the point prevalence audit checklist provide the privilege to find out the areas to be improved, along with the nurses are empowered to take timely effective action after consulting with the on-duty supervisor and calling rapid response team. As a result, there is a significant reduction in occurrence of code blue, that is only 1 or 0 in the last few months. So repeated training and close monitoring and continuous audit can reduce the number of adverse events and increase the rate of patient survival. Here the list of reference we referred during the project. Thank you everyone for your kind listening, and once again I would like to thank to ANEI and Patient Safety Movement Foundation for this wonderful opportunity. Thank you so much.
That's another great project. You know, I used to go into work at 4:30 in the morning in the office so that I could write papers and not be disturbed, and then go on to clinical just after 6. And I knew when it was 6 a.m., not because I had a watch on, but because I'd hear 2 or 3 code blues. And it's almost, the reason was that the nurses were changing shift and they'd go in and check on the patients. And that's when they realized someone had been deteriorating over the last few hours and was in trouble. And so, you know, our cars seem to have devices on them now that you don't bump into somebody else. Many people have a watch that'll measure your pulse rate or measure your oxygenation. I think the technology's got to increase and become cheap enough that we could put a small monitor on every patient that would transmit to a smartphone, the nurse's smartphone, so you'd know when the heart rate increased or decreased. You'd know when oxygenation started to deteriorate, because we should not find these patients basically dead in bed in a hospital. And I think the technology, this is again why I think MedTech has to be part of our patient safety army, because you've done a terrific job, but I think with an extra tool, you could have that patient monitored 100% of the time, just some small thing, maybe it's just pulse rate, but at least it would go to your smartphone and you'd know this patient's in trouble, go check on them. So congratulations, it's very important, and let's hope we can even do better with more technology. Thank you.
Thank you so much, sir.
Thanks, Purba, and thank you, Dr. Michael. So we will move on to the next project. Just give me a minute. Next, we have Ramya. In case you are not able to see here, let me know. I'm just adjusting my screen.
A very warm good evening to respected dignitaries, and a special evening to Dr. Michael Ramsay. I am myself Ms. Ramya, a Patient Safety Fellow of Cohort 2. to begin with and embarking on a 1 year and 4 month of journey filled with innovation and collaboration. It was a great learning opportunity for all of us. We are gifted to be in this platform of ANEI and Patient Safety Foundation movement. It again, ANEI has proved that learning can be made possible across the world. To share a few experiences of my learning journey in a Patient Safety Fellowship, we have been shared a patient safety curriculum which had helped us to promote a reflective thinking process. Along with that, we had a couple of meetings with Ms. Olivia and Dr. Michael Ramsay, where we had shown our roadmap of QIP project. I take an opportunity to thank Dr. Michael Ramsay for his enormous support. Thank you, sir. I thank Ms. Tankam ma'am for her unwavering support. Without her, this journey wouldn't be possible. Thank you, ma'am. I thank Dr. Jadav Sonali Tarachand, a principal of Ramaya Institute of Nursing Education and Research, who was a reason to begin this journey and also to be a part of an ANEI. Thank you, ma'am. I thank all the cohort 1 who was helping us to make this journey successful, and my special thanks goes to Vinod, Miss Shiny ma'am and Miss Priyanka ma'am. Thank you. Also, I congratulate all the cohort 1 for their rewarding success, and hearty congratulations to all of you. I'm highly privileged to present my quality improvement project on surgical site infection prevention. I am now sharing my slide share. The title of my project is a quality improvement project on surgical site infection prevention. As we all are aware that surgical site infection prevention is the most frequent type of healthcare associated infection. The hospital where I carried out this quality improvement project, there were around 10 patients who were found to suffer from surgical site infection rate, which has contributed to 0.7% of the surgical site infection rate. Surgical site infection rate. The main aim of this quality improvement project was to reduce the surgical site infection rate. My project team was, the study was carried out in Ramaya Medical College Hospital, which was an 800-bedded hospital. Champion was Dr. Beena. I was a project leader. My mentor was Ms. Shiny Varghese. The team members were Dr. Beena, Ms. Lima Matthew, nursing superintendent, Ms. Jayalakshmi, OT in charge nurse, and Ms. Shobha was a OT nurse. The aims and objectives of my study. The aim was to reduce the surgical site infection rate from 0.7 to 0.3%, and the objective was to identify the existing cause leading to increase in surgical site infection, to develop a standard guideline checklist to prevent surgical site infection rate, to evaluate the effectiveness of standard checklist in prevention of surgical site infection rate. The methodology adopted for this project was PDSA, where I had carried out the audit on identifying the surgical site infection rate from the month of December 2022 to May 2023. Once the SSI rate was found, the root cause analysis was done for each of the surgical site infection, followed by identifying the root cause analysis. The plan was carried out to prepare the surgical site infection prevention checklist. This was the plan adopted. In terms of my objective 1, this is a graph which represents the total number of surgeries that has been carried out between the month of December 2022 to May 2023, where it was ranging between 650 to 850 surgeries. This table represents the highest rate of infection was found in the month of January, which is contributed as 1.1%, whereas the lowest rate was found during the month of April 2023, that was 0.29%. This is a graph which represents the surgical site infection rate between the month of December 2022 to May 2023. In terms of surgeries performed in RMCH hospital, there were around 12 specialty surgeries which was conducted in this hospital. This is a graph which represents the surgical site infection rate that was analyzed department-wise. In that aspect, the highest rate of surgical site infection was found in general surgery department, whereas the lowest surgical site infection rate was found to be in urology department, whereas the other departments such as orthopedics, surgical oncology department, and obstetric and gynecology department were found to have an second highest surgical site infection rate. Coming to the root cause analysis, the root cause analysis was done for every specialty. In terms of general surgery, the root cause analysis was comorbidities, diabetes mellitus and hypertension, contaminated surgery, spillage of bile during surgery, and increased hospital stay. And also there were poor aseptic technique was performed, was followed while performing dressing. In terms of surgical oncology, the RCA was found to be clean contaminated case, prolonged malnutrition, and poor aseptic technique while performing dressing. Whereas in orthopedic surgery, there were a breach in asepsis while handling instruments and increased hospital stay and infection due to poor hygiene. In terms of obstetric and gynecology, the root cause analysis was typhoid fever, comorbidities such as diabetes mellitus, morbid obesity, and pre-existing anemia. In terms of urology, the root cause analysis was breach in asepsis. Once the root cause analysis was identified, we had started with intervention phase such as creation of surgical site infection prevention checklist. This SSI checklist was prepared in collaboration with the HICC committee. Once the checklist was prepared, this checklist was shared to a OT nurse, where the OT nurse follows this checklist when the surgeries are performed. Followed by the implementation of the surgical SSI bundle in the month of July and August. So this is a graph which represents the total number of surgeries that has been performed during July to August 2023, whereas in the month of July, total number of 881 surgeries has been carried out, whereas in the month of August, 773 surgeries has been carried out. This is a graph which represents the surgical site infection rate in the month of July, which was 0.34%, whereas in the month of August, it was found to be 0.1%. When the analysis was carried out department-wise in the month of July and August, in the month of July, the surgical site infection rate was found to be equally high in general surgery department and orthopedic, whereas the surgical site infection rate was nil in surgical oncology, obstetric and gynecology surgery, and urology surgery. Whereas in the month of August, the SSI was found only in the department of obstetric and gynecology, which was 0.1%. This is a graph which represents the comparison of pre-intervention and post-intervention phase, where the SSI rate started with 0.72% during the pre-intervention phase. And after the post-intervention phase, there was a reduction in SSI rate, which was found to be 0.10%. In a way forward, the data shows that there is a significant reduction in surgical site infection rate from July to August 2023. There were many challenges that has been faced while implementing this surgical site infection checklist, but the implementation of this checklist was found to be effective. Yet the hospital management has planned to continue the SSI checklist in future to maintain the consistency in reducing the surgical site infection rate. The references that I had referred is here. Along with that, we also used Patient Safety Movement Foundation, the guidelines which was given by them. Thank you all for your support. Thank you.
Ramya, thank you so much. That's a very important study. I'm really impressed with these studies that you've done. I noticed that you included blood glucose on those patients and you were measuring it. Were they treating it to keep it down, to make sure that the sugar didn't get high during that study or not? Or were they just recording what the sugar was?
Yes, sir. We do check the CBG, capillary blood glucose level, before the patient is put up for surgery.
Okay, all right. Well, I think it's very important. I like the fact that your infection rate already was pretty low, which was good, because in many institutions it's higher than that, depending on the type of surgery. So I think you've got to be congratulated. You made a difference, and that's what's important. Thank you so much.
Thank you, sir. Thank you, ma'am. Thank you, sir.
Thank you. Thank you, Dr. Michael. Thank you. I just have one very quick question before I forget, because Dr. Michael is an anesthetist. So I just wanted to know, how important is it to maintain the blood sugar during surgery? Before surgery, yes, we make sure they are, under control. Some documents say less than 180 or keep it below 200. How important is it that intraoperatively the sugar should be monitored and controlled?
We certainly had, we did a study like that, very much like Ms. Ramia's, and we looked at not only blood sugar and making sure it stayed below 140 through all the case of colorectal surgery, which was one that had one of our highest wound infection rates, but we looked at body temperature as well and made sure that the patient didn't get cold. And we looked at the antibiotic given. Was it the right antibiotic, and when was it repeated? Was it right dosed, etc.? So we looked at several things that affected anesthesia. We were able to bring the infection rate down as well. Once we publicized the data, we made sure that everybody involved in the case knew the data, and we showed it to them. We didn't punish anybody. We just showed them and said, look, this antibiotic was not given on time. It needs to be given before the skin incision. And gradually people, once they saw their data and they could see everybody else's, they changed. So I think information is a powerful tool that makes people change practice. And so that's how we were able to bring our infection rates down, but not to zero yet. So I'm going to take some tips from Ms. Ramya and see what we can do differently as well.
Thank you. Thank you, sir. Thank you very much, because that is something that I used to be keenly interested when I was in hospital, to look at all the other factors that you are mentioning. The WHO has got a beautiful document which talks about so many factors in a pictorial format, and it's very easy to understand that different surgeries, different thing needs to be monitored, So great learning. Thank you, Ramya. And we will move on to the next presentation. I'll just close this away. Next is Dr. Rosaline.
Hi, everyone. I'm Dr. Rosalind Rachel, Principal of the Madras Medical Mission College of Nursing. As a part of the ANEI Patient Safety Fellowship Program, Cohort 2 2022-23, I'm here to present my project. Let me share my screen. Right, the quality improvement project on handoff communication at an intensive care unit. This study was done at the Madras Medical Mission Hospital, Chennai, Tamil Nadu. The champions were Ms. Sharon and Ms. Julin, and my mentor was Ms. Thangam Gomez, the founder president ANEI and the former president of the Association of Nurse Executives India. The team members were Ms. Sheila and Ms. Maria. The need for the study, as we are all aware that handoff is one of the important communication the nurse does between two nurses while receiving or while handing over the patients from one to the other. Many unsafe practices and unidentified cases reporting was noticed during my observation. Incomplete handover while receiving patients from the operation theater to the ICU, from ICU to ward, or during shift handover. Late handing over, that is shift overlap. Clients identified by the operating surgeon and they were not identified by their name or UHID number. A focused physical examination was not conducted. Read back or restate information was not practiced. Missed observing and reporting on incidences like cautery burn, pressure injury, accidental delining, and extravasation was unidentified during the pre-intervention period, and 1 case of medication error and missed reporting on incidences, 2 cases, which means that they have identified, not reported, but it was kept under the carpet. The root cause analysis, the process of handing over was not checked. Though errors were happening, the junior nurse was blamed as the system was not strengthened. The quality of verbal and written handoff process was not standardized. The objective of the study was to assess the pre-handoff communication before the training for 1 month, to conduct co-training workshop for IPAS before implementation, that was for another 1 month, and to assess the post-implementation on a reduction of errors, that is preventable adverse events. After a period of 3 months, the observation was done to assess whether it was effective. The methodology used planned to assess the present handoff communication, to identify the number of errors. As I said, 1 month was used for the assessment, and to identify the patient's assignment system, special duties assigned, number of patients assigned for each staff nurse, duty timings, and to assess the IPAS tool prepared observing the nurse exact handing over method from OT to ICU during shift changeover, or from one nurse to another during transfer from ICU to step down ICU or ward, and to conduct the workshop using simulation-based scenario, and to teach how to hand over using IPAS, to ensure that every nurse follows the written IPAS handoff communication, and after 3 months of implementation, to observe the effect of IPAS implementation. Based on the Patient Safety Fellowship movement, evidence-based studies, the tool was prepared as modified IPAS from shift handover and inter-unit transfer. The acronym used was I stands for introducing self to the patient, identify the patient by name, age, and UHID number, and illness severity, whether the patient was stable, unstable, or whether the patient has to be transferred or discharged. And P stands for the patient summary, A stands for the action list, S stands for the situation awareness. These are all done by the outgoing nurse when she's handing over to the incoming nurse. And the last part of S stands for the synthesis by the receiver, which is the incoming nurse. She summarizes the events. Let's see the study findings to understand this better. The first part component was I, which stands for introduce self and identify the patient and illness severity. As you all see, during the pre-implementation, none of them had the habit of introducing themselves by their name and who they are and how long they will be with the patient. 97, during the post-implementation, we found a drastic change, and identification was done based on the cardiothoracic surgeon who operated on the patient and not by the patient's name or the UHID number, which improved to 98%. And illness severity, 52% of them spoke about the illness severity, which improved to 96%, as whether the patient was stable, unstable, he needs an observation, or he has to be transferred. These informations had improved. The second component of my study was on the acronym P, which stands for patient summary, and relevant past medical or surgical history, primary diagnosis, comorbidities. In all these 3 areas, the patient would have come to the hospital with a previous illness, or he has come for some other problem and a cardio problem was identified and he had to be operated. So those things were never mentioned in the ICU, and during the post-implementation, we found in all these 3 areas, there was an improvement. And clinical chief complaints with duration of whatever care had to be given for the patient was not missed, because they were able to present about the chief complaints with which the patient had come in. And the hospital courses, there were certain things like the type of medications which were used, what are the investigations, what is the diet, diagnostic studies, consultation, and the treatment. And this included only 8% of the pre-implementation period. It was an 8%, which improved to 93% post-implementation. These patient summary gave a very good impact on the quality of nursing care which they had to give, because only the cardiothoracic part was looked into, and certain other drugs which was taken by the patient earlier was missed out, and this had improved during the post-implementation period. The third component of the study was the action list, to-do list, pending results, consultations and procedures from 3% to 39.7%, and the timeline, prioritization and ownership. This was all present during the pre-implementation period, where about 87% of them had the ownership of the patient, which improved to 99%, I was happy to see this improvement. And related to the diet would have been cancelled at the ward, and when the patient comes after surgery, immediate attention was not given during the pre-implementation, whereas in the post-implementation, 96% of the patient had the diet ordered on time and received and given on time. Medication given pending and any special points which had to be done. Only 3% gave attention to any type of special events. The routine medications which was ordered by the surgeon, sometimes the chart hadn't come from the operation theater. They were waiting for the chart, and some informations like the past medications which had to be continued was missed out during the pre-implementation. So we made it a practice that the record be received and the surgeon can write the report and then send it to the ward, which improved to about 91.50%. So this again had a very good impact on the nursing care, quality nursing care for the patient. The fourth component was the situation awareness, hemodynamic status. If you see, it is the monitors were there. So it was a habit to look into the monitor at the time of handing over. The past hemodynamic status and what medication was given, which had improved the patient condition, was never mentioned during the pre-implementation phase, whereas during the post-implementation phase, 92% of them had presented about the hemodynamic variability and the medication given. Ventilator care was good even during the pre-implementation, which improved to 99%, which was excellent. Tubes, lines and drains was mentioned during the report, but it was not checked, which improved to 91%. Suggestion plan for the overall treatment from 68 to 70%. Anticipated problems in the next 24 hours. The nurses were able to already anticipate, but that improved to 94%. Critical lab values, again, a written report was given in hand so that any critical values which had to be collected and informed to which surgeon or anesthetist or the intensivist was clearly mentioned during the post-implementation period. This also improved the quality of patient care, and near miss events was also identified due to this particular area. And the last component was the outgoing nurse responsibility to summarize, ask questions, clarify doubts, and she reads back the key actions and checks on the tubes, drains, lines, and also the skin integrity, and also cross-checks the record. So we found a very good improvement in the post-implementation, wherein the doubts were clarified very clearly, and the recording also was checked, and the nurse who had to go out was made sure that she had completed her recording, and we had less incidents of calling the nurses from the quarters to come back and do the post recording. Coming on to the summary, as mentioned earlier, it was a systematic method of handing over became a practice, and self-introduction and identification also became a practice, and the incidents during the post-intervention like cautery burn, pressure injuries, accidental delining, extravasation was identified, medication errors were identified, and missed reporting on investigations was zero during the post-implementation, which showed a very good improvement during the post-intervention period. And readback of information was also ensured. And the important thing here was the shift timing. As I said, there was an overlapping of shift timing as mentioned here. I thank the administrators for making a fervent effort towards the well-being of the nurses and for the betterment of the patient care. And the clients received a holistic care which reduced their stay at the intensive care unit. Way forward, spread the good news to other units in the hospital, and we are planning to implement to all the other units. The process change was accompanied by training and guidance by the unit that has championed the change, and continue the process of audit map and adverse events before and after the introduction of the modified IPAS for all types of handover among the nurses, work with the nursing administrators to firm up the clinical indicators for the quality improvement. These are my references. At this outset, I would like to thank ANEI for giving me an opportunity, and the Patient Safety Fellowship movement for giving me an opportunity to conduct the study. Thank you, one and all.
Dr. Rosalind, that was amazing, great results. And it's a problem in all surgical ICUs for sure, because I experienced it myself a lot. And when we did similar studies, and when you're doing the study, everything improves. The problem comes once the once they know they're not in the study, things start to deteriorate again if you're not careful. In other words, you'll take a patient to the ICU and the staff are busy with another patient, and they really don't have the time to come and receive that patient. Well, are you prepared to wait there with that patient, because the OR wants you back in the OR, and suddenly time constraints become a part of the equation, and yet you've got to be rigid about it. You've got to do a good handover, and yet there's pressures on the staff to not make it as good as it was when they were in the study. And so you have to repeat it every so often to make sure they're online and doing it properly, because it's vitally important that that handover communication is done. So congratulations.
Thank you, sir. Thank you. Thank you, ma'am.
Thank you, Dr. Michael. Thank you. IPAS, there is a IPAS Institute itself now. In US, there is a IPAS Institute where they have got the technology solution for doctors as well as nurses. So there's so much happening around handover, and I'm sure that who else apart from doctors and nurses would know how communications break down, and that leads to patient harm. Yeah, thanks.
Absolutely.
Yeah. So let me go to our last presentation, that is Ms. Saujanya. Let me just close that and I will get Saujanya on.
Namaste, everyone. I'm so happy and privileged to be a part of ANEI Patient Safety Fellowship program. I extend my sincere gratitude and thanks to ANEI and Patient Safety Movement for giving this wonderful opportunity to be part of this Patient Safety Fellowship program. I also extend my sincere gratitude to my mentor who helped us in each and every step what we do during our quality improvement project. I would like to explain in detail about my quality improvement project, which I've conducted at multi-specialty hospital of 1,000-bedded hospital. Give me a moment to pull up my slides. Here we go with my presentation. Let me explain in detail. The quality improvement project on reducing pressure injuries in the hospital. As we all know that the pressure injuries are the worldwide health problems which occurs 1 million of patients every year, and 60,000 of patients are dying from the complications. The incidence ranges from the 4% to 38% in the hospitalization patients, and the mortality rates are due to the pressure injuries, especially among the elderly population of 68%. In Indian setting, the prevalence of pressure injuries in the hospitalized patients has been reported, and to prevent the pressure injuries, it is very essential to provide the better nursing care to the patients. And also, the pressure injuries are most affected by the attitudes of the nurses. And we, as a nurses, it is very responsible for us to understand the skin integrity and preventing of its complication. And I would like to extend my sincere thanks to our project team. So under the championship of Mrs. Harita Vijayan and my mentor, Mr. Vinod Kumar, and the teammates for helping me and guiding me through this complete QIP project. And the title of the study, the Quality Improvement Project on Reducing the Pressure Incidents in the Hospital. The reason for me to choose this topic are every month there are the reported cases, and which creates a dissatisfaction of a nurse, patient, as well as the family, which denotes the lack of proper preventive measures had been adopted in the hospital. The reasons are mostly under reporting cases, there is no standardized protocol, and SOPs are not being adhered, and inadequate knowledge in the pressure injury preventions. As we can see the incidence of pressure injuries in the hospitals, we can see that every month there are the reported cases, and hence the team has decided to begin the project and would like to bring down the pressure injury rates of less than 0.1 per 1,000 patient days, and it is one of my aim of this study. And the main objective of my study are to implement the evidence-based multimodal strategies and to standardize the best practices across all the patient units and to enhance the competencies and knowledge and attitudes of staff nurses. I have adopted the PDCA cycle, wherein I have identified what are the main gaps here, and based upon it, I planned the questionnaire multimodal strategies and applied to the nurses, and also conducted various training sessions and regular intervals, and daily surveillance of quality nurse has been implemented in order to understand what exactly happening in the clinical areas. And I have included the total 137 nurses have been participated in the study, where 40.1% of the male nurses and 59.8% of the female nurses. When I look at the level of nurses, the 61.3% of the staff nurses and 29.1% are the trainee, and the 9.4% are the in charges are participated. And then the department wise, that are 37.9% of the staff are from the ward areas, and majority of the nurses from the critical area, that is 62% of the nurses. And here, let me explain in detail about the components of the staff knowledge, where I have been divided into 6 components, and each component has been assessed the knowledge level of nurses. Let me explain in detail about each component. And the staff nurses' knowledge on assessment of stages of pressure injuries. So here in the pre-test, so I could able to see that only 49.22% of staff aware about the stages of pressure injuries, whereas in the post-test, the knowledge level has been increased to 95.3%, and 4.08% said that they are not aware about the stages of pressure injuries. And moving on to the next slide. The risk factors. So the nurses in the pre-test, 51.4% have said that they are aware about the risk factors, whereas in 48% said that not aware. In the post-test, we could see the gradual improvement in the nurses' knowledge, where 96.4% said that they're aware about the risk factors. And about the identification of pressure injuries, so pre-analysis clearly says that 42% are only aware about the identification of pressure injuries, whereas in the post-test, we could see that 91.9% are aware about the identification of the pressure injuries. And when I look at about the skin integrity and the staff knowledge levels, so in the pre-analysis, we clearly showed that only 44.5% are aware of the skin assessment, whereas in the post-test, I could see the gradual improvement in the nurses' knowledge level, that is 92.9% are being aware about the skin integrity. And the staff nurses' knowledge about the nutrition, so in the pre-test, the people clearly said that, okay, 47.4% are only aware about the importance of nutrition in terms of healing of pressure ulcers, whereas in the post-test, major of the nurses are aware about importance of nutrition, that is 95.6% are clearly aware about, and they felt that, okay, it is very important in the healing process of the pressure injuries. Analysis knowledge about the prevention and management of pressure injuries. So whereas the 41.4% in the pre-test clearly said that they are aware about the preventive measures, whereas in the post-test, 93% have said that, okay, they are aware about the importance of prevention of management. And let me explain in detail about the staff attitude towards the pressure injury prevention. And here I have chosen the 11th, the attitude questionnaire in views of the pressure injury preventions. Let me explain in detail about each parameter. All the patients are at potential risk of developing pressure injuries. So whereas in the pre-analysis, 71% of staff said that, okay, the patients are not at the development of pressure injuries. Whereas in the post-analysis, 96% of the staff had a positive attitude, whereas only 4% said that they are not a developing of risk for pressure injuries. And continuous assessment of patient will give an accurate account of the pressure injury as risk. So whereas in the pre-test, 94% have believed that continuous assessment will not give any kind of account of pressure injury assessment, whereas in the post-test, 93% of believed that it is very, very essential to monitor and assess continuous assessment during the hospital stay in order to identify pressure injury as risk. Most pressure injuries can be avoided. So in the pre-analysis, 84.5% believed that pressure injuries cannot be avoided, whereas in the post-analysis, 93% of the staff had a very good positive attitude, and they said like it can be avoided, and only a 7% of opined differently. Pressure injuries risk assessment should be regularly carried out on all patients during their stay in the hospital. In the pre-analysis, only 56% of believed that risk assessment should not be carried out regularly, whereas in the post-test, the attitude of nurses clearly denotes that 93% of them said it should be carried out regularly. And pressure injury prevention is a time-consuming for me to carry out, whereas in the pre-analysis, 76% of believed that it is a very time-consuming activity, whereas in a post-test, 88% of staff felt it is not a time-consuming activity, it has to be continued. In my opinion, patients tend not to get any procedural injuries nowadays. So for this opinion, 82% of a staff believed that okay, the patient don't get any procedural injuries nowadays, whereas in the post-analysis, 82% of a staff believe that they do get the procedural injuries in the hospital nowadays. And I don't need to concern myself with the pressure injury prevention in my practice. So 68% of staff believe that no need to concern about the preventive measures. And the post-analysis clearly state that 83% of had a very good positive note in prevention of pressure injuries during in my practice. And pressure injuries treatment is a greater priority than the prevention. So whereas in the pre-analysis, 68% of them believe that treatment is the first priority than the prevention. Whereas in the post-test, 85% of believe that prevention is the most important than the treatment option, whereas 15% express different opinion. And I'm less interested in pressure injury prevention than the other aspects of care, whereas 56% of them clearly believe that it is very less interested, whereas in the post-analysis clearly state that 85% of them are interested in prevention of pressure injuries. In my clinical judgment, it is better than any pressure injury risk assessment tool available to me. In a pre-analysis, only 66% of staff believe that my clinical judgment is better than any kind of risk assessment tools available in the hospital. Whereas in the post-analysis, the attitude of nurses has been changed, that they felt 80% of them, the clinical judgment is not priority, but the assessment tools are the most important than my clinical assessment. In comparison with other areas of care, pressure injury prevention is a low priority me. So 52.3% of the staff believe that, okay, it is very low for them, whereas in the post-analysis, 82% believe that it's the first priority for them than anything else in the other areas of the care. So let me explain the best practices, what we adopted. So the daily surveillance of patients by a quality nurse is a mandatory. We made very strict on note, and introduced the concept of tissue viability nurses for positioning and providing of care to the patients who are at risk of development of pressure injuries. And we also involved the patient and the family members in prevention of pressure injuries. And we formed a team of improvement team of pressure ulcers, that is the critical care doctor, ER physician nurses, and tissue viability nurses and educators are the part of it. And implemented the position chart for the patients, and the regular intervals of audits have been conducted to understand what the practices are being practiced in the hospital. And huddle sessions and the clinical teachings are being practiced in the department. And we can see the gradual improvement in the post-analysis, and there is a reduced rate of pressure injuries of less than 0.1% in the month of August. So way forward, so I would like to continue to implement the same in the upcoming months in order to maintain the sustainability in the clinical areas, and nurses are empowered to take the decision in view of better patient care. And also we wanted to repeat the trainings, close monitoring and continuous audits so that we can reduce the number of incidents and we can sustain going forward. And these are my references. And thank you so much. And once again, I thank all the mentors and the ANEI and Patient Safety Movement for giving this wonderful opportunities. Thank you, everyone.
Major problems in healthcare. So I've got to congratulate you on that. And particularly now, you involve the family in this one, which I know Dr. Neelam Dhingra tomorrow will talk a little bit about, because that's what the WHO want us to do, is get family engagement, patient engagement in what we're doing. Yours was an educational study. So the question I would have is, how often do you have to repeat that education? Do you have any thoughts on that?
Thank you, Doctor. The education, it is a continuous process which we wanted to continue, as it is most important in order to sustain our study as well as to reduce the pressure injuries in the hospital. It is not the one way of going. It is a regular trainings and the clinical trainings which we are implemented at the bed level during the shift handover timing. So it's a small huddle sessions as well as every continuous nursing education which we have been implemented.
Good for you. That's the right approach. I think it is something you have to keep continuous. So thank you. Tremendous presentation. Thank you so much.
Thank you, Doctor. Thank you, ma'am.
Thank you. You're muted.
Ma'am, muted.
Sorry. Yeah. I said thank you, Dr. Michael, for really sitting through every single presentation. I can imagine early morning how it will be, because this is for me a little late. I am also feeling tired. I can feel that, but the high point is that all of them could shift from one point to the other for betterment of patient. And my only request to all my dear fellows is that don't stop doing anything. You have to sustain and you will continue on the path, because it never stops. It never stops. So, sir, thank you so much. Since you had your questions and your thoughts you have already given, we are very much on time. The next will be the awarding of the certificates to our cohort 1. And to do that in a virtual format, I have got the e-certificates, which I will be presenting, and Dr. Michael can announce that, you are giving it to them. And we can do a virtual clap like this without making too much noise. Otherwise, it will become too noisy here. Is that okay, sir?
Absolutely. Yeah.
Yeah. So let me just pull up that presentation, and let me just close that one. So that's the first one, sir.
So the first certificate is awarded to Miss Anita. Now I'm going to hard names. Faya Kumar.
Yes, sir. Thank you.
Okay.
Today she's not able to come on video because of her health issues, but she's there. And congratulations, Anita. Thank you.
You bet. And next is Dr. Biyaya Tongan.
Tongan. Yeah. Congratulations, Vijaya. They all will be giving, 1 or 2 minutes of their thoughts once after we have announced their certificates. We'll be giving them yeah.
All right. The next one is for Miss Ishita Chanda.
That name was easy. Congratulations.
Yes.
Yeah.
And
now that's going to be a tongue twister.
Okay, next one's a little harder. Miss Priyanka Shirsaf.
Oh, you got it so right. You said it's so harder, but you got it so right. Congratulations, Priyanka.
Thank you. And the very next one is Miss Glory Emmanuel.
Yes, sir. Congratulations, Glory. So Glory is now in UK. She started when she was
really?
here, and now she's in UK. Yeah.
Thank you, ma'am. Thank you, sir.
Okay.
Oh, you're there. Congratulations.
And, next one is
Shiny.
Shiny Varghese.
Varghese, yes. Congratulations, Shiny. Thank you. Next is the only Mr.
And the last one, yes, Mr. Vino Kumar.
Yes, congratulations, Vinod. And Vinod had been hugely helpful in setting up our Google Classrooms and putting the content there and tracking what's happening with the fellows. So he has also offered to continue to do the same for the next cohort as well. So thank you, everyone. Together we achieve. Congratulations to all. And sir, with your permission, I'm going to ask them to go one by one and tell their thoughts around their journey. So Anita is not able to, participate today for health issues. So we go to Dr. Vijaya. Like to say something? Dr. Vijaya, are you there?
Yes.
If Dr. Vijaya is not there, Ishita?
Yes, ma'am.
So good evening to all, and good morning to Dr. Ramsay. So I'm grateful to ANEI, Madam Thankam, Dr. Dona, Miss Olivia, and Dr. Ramsay for enabling me to successfully complete this 2 years course on Patient Safety Fellowship. So when we started our journey, we didn't know where was a path leading to, but now we have a very structured goal ahead of us. And I'm grateful for this platform for it was an experiential learning for me, and it has helped me a lot. And it's also shaping me in my professional career as I take up the nursing quality in my hospital where I'm working to. So it's been a pleasure working with the team over there. And thank you, Tankam ma'am, and everybody in this team. And all the best to cohort 2 and cohort 3 as they also will bloom as we have bloomed. Thank you, one and all.
Thank you, Ishita. Over to Glory.
Hi, good evening to everybody. Good evening. It's a great opportunity to meet Dr. Ramsay, and thank you so much, Annie and Dr. Ms. Tangam, for giving me an opportunity to be in this project. So it was an incredible journey. It was an eye opener for me as a nurse, basically, and then to implement a lot of these projects personally in my workplace as well. And specifically, I would like to give thanks to Dr. Ticlara to motivate me to join the cohort. And I wish all the best for cohort 2 and cohort 3 to do a great success, as some projects they did were wonderful, and it's gonna be a lovely a project. So as Dr. Ramsay said, we are all patient safety army to promote patient safety wherever we work through. Thank you so much for the opportunity.
Thank you, Glory. Thank you very much. We move to Priyanka. Okay, connectivity is an issue, so we move to Shai. Priyanka, okay, are you
Yes,
there?
ma'am.
Okay,
Yes,
go
ma'am.
ahead.
A lovely evening to you, Tangam ma'am, a visionary, consistent, and visible leader through whom entire nursing fraternity in India is blessed, promoted, and transisted today. A lovely evening to Captain Ajita ma'am. It's a proud moment for me to witness today's happiness with a prominent leader like yourself along my side today, ma'am. Thank you for your presence. Namaste from India to Dr. Michael Ramsay, sir. It's indeed a privilege for me to be a part of today's event where I am sharing this enormous platform with such a defined and prominent leader like yourself in the field of patient safety. Sir, it's an honor to have you with us here today. A love-filled hello to all the fellow colleagues, cohort 1, a loud shout out to all the fellows of cohort 2, and a welcome for a roller coaster ride for all the fellows of cohort 3. It's a delight to witness today's day where me and my vibrant colleagues are being acknowledged and awarded for our successful completion of ANEI Patient Fellowship Program today. I am Ms. Priyanka Nitin Shirsat, working as a quality manager, Global Hospitals, and a proud fellow of ANEI Patient Fellowship Program, Cohort 1, would like to extend and express my heartfelt gratitude towards my God Almighty who made me able to become who I am today. I'm also grateful to Tangam ma'am for providing me with one in a million opportunity to become a part of this fellowship program, for protracting what I already had and integrate within me what I learned, observed, and evolved understanding about patient safety throughout this journey from 2021. I am forever in debt to Annie, which provided me with this boundless platform to widen my horizons while learning and developing myself professionally in all aspects. Journey of ANEI Patient Fellowship Program was never easy. It was never meant to be. We had to earn each and everything it had to give us. Right from giving a tough interview to find our place in this fellowship program, to proving ourselves through different and difficult tasks through which we were constantly evaluated, and stand true to all the expectation of our leader, Tangam ma'am, who expected us nothing but to deliver at the excellence level. Getting chest in with continuous corrections, redoing things, and getting it not only right, but going beyond our thought process is what this fellowship program was all about for me. Road was never smooth. With lots of ups and downs, we learned spontaneity and thoroughness in every aspect there might be related to believing and promoting patient safety. Well, today I was thinking, if anybody asked me, what did I get from being a fellow in this fellowship program? I can proudly say that today I function as a patient safety champion, IHH India Global Hospitals, which is no doubt more larger than anything I could have ever thought of. With responsibility and accountability, I stand tall and proud because what changes I can now bring and execute for my patients are more than anything I could have ever imagined at the start of this fellowship program. Once again, I thank Tangam ma'am, Dr. Donna, Dr. Michael, Dr. Jyoti Clara, my fellow colleagues, my family, and everyone who have lovingly, patiently contributed throughout my journey. Thank you so much.
Thank you, Priyanka. Is Dr. Vijaya there? She's having some connectivity issue. We'll wait and we'll move on to Shiny. Shiny, are you there?
Ma'am. Yes, ma'am. Thank you very much, Dr. Ramsay, Tanga ma'am, and all the dignitaries. It has been a wonderful 2 years of journey, and the time went by so fast. And now here we are getting graduated from this fellowship, and it has added tremendous value to each and every one of us. And thank you for this opportunity to be associated with this prestigious movement, which enlighten us tremendously to know that the very important person what we serve is our patients. Thank you very much for this opportunity, and the learnings what we have gathered from here will be continually be spreading light to all the people, all the nurses, all the patients who would come across to our touch. Thank you once again for this opportunity. Thank you.
Thank you, Shiny. Once again, call out to Vijaya. Are you there, Vijaya? Okay, I think Vijaya is having connectivity issue. So we move to our lone warrior, Mr. Vinod.
Good evening, all Indian participants over here, and my esteemed mentor, Tankam ma'am, and ANEI current president, Captain Ajita, and I. A very good evening to all the ANEI team members who are present over here. And very good morning, sir, Dr. Michael Ramsay, sir. So it's been a pleasure to be a part of this ANEI Patient Safety Fellowships, and the journey from 2021. I can say it's not an easy journey which we had. There are a lot of hard work, and all my colleagues we put together. And first, when we are starting, it was a bigger vision on how we can promote this patient safety fellowship through the PSMF members. And later, with the vision of Tankam ma'am, we got a skeletal formation for that patient safety for our own nurses, how we can tailor WHO curriculum to be implemented here in the patient safety fellowship for our own nurses in India. So that's been an honor, it's a great honor to be part of this team. And I would say mentor like Tankam Gomez, who's seen me from the novice level, where even I can confess that I was struggling to even present a presentation in front of 3-4 audiences earlier period in 2014-15, and now I am being into a level where I can do QAP projects alone. I'm doing all my educational programs for doctors, nurses, and even senior anesthetist and senior intensivist, where I collaborate in clinical research and clinical paper presentations for them. So that's what this, a change can occur. And the same mentor who is working throughout these years in all these patient safety movement has completely groomed me. And now, though I am not a part of an hospital nowadays in my current role, but now it's given an open opportunity for me. And Dr. Ramsay, even believe me, by using these actionable EBPS practices, then it was called as actionable points patient safety SS solutions. So through that, across India, I alone handled 3 QAPs, which is going to complete in the coming years. And we have done a lot of protocol development in pressure injury preventions in all the zones in India, like South, North, East, and West. So I'm proud to be part of this, patient safety fellowship program where it groomed me in a different way and moving into the right objective of making no harm for the patient who is admitted. So thank you so much for giving this opportunity for me. And I would like to extend and share my knowledges to my fellow colleagues, cohort 2 and cohort 3 in the coming years. Thank you.
Sorry, thank you. Thank you, Vinod, for that kind words. Thank you, all of you. Vijaya, Dr. Vijaya is still having some trouble with the connectivity. If she comes in, well,
Ma'am,
we'll
she's
ask
here.
her. Sorry?
She's here joined.
I'm seeing her, but then she goes away. Hello? Yeah, she came for a second and then she's gone.
Hello, Vijaya.
I'm here, ma'am. Actually, it got disconnected in between.
Okay, okay.
Ma'am, good evening, everyone. I'd like to extend my sincere gratitude to all the ANEI executive members and especially thank you, ma'am, for choosing me and giving this opportunity to be part of this Patient Safety Fellowship. And also today, Dr. Ramsay, sir, for his auspicious presence and for his support. It was a wonderful journey for me, though there were so many meetings and and presentation, but that has molded us professionally as well as for this program, for this fellowship. I also would like to thank my team members for all the motivation and supports. And now a warm welcome to all our new cohort 3 members into this new journey. And together we know we can change it for the betterment of the patients. We realize it only when we are patient. So thank you, everyone, once again.
Thank you, Vijaya. Finally, we could get you in and we could hear you speak. I just want to say one thing. Many of you took my name and say, I don't know, I did something. But I would say that it had been a great learning journey for me. It keeps me young and it keeps me motivated that, I'm still able to touch patients. I'm not working in hospital. Through each one of you, I feel that I am reaching out to patients. So that's a blessing for me. So it's nothing great. And this is something very close to my heart, that I can make a difference to patients, and you are all my instruments. So that's why I continue to hold on to this fellowship program. I did tell Ajita, I'm not giving it away now. I'm going to hold on to it. And all of you all gave already the next cohort warning. It is not going to be that easy. It's just to make sure that you carry something from this fellowship, not be here just because there is a prestigious program, so that tomorrow Dr. Michael should also feel proud that, though he's sitting there in US, he is also making a difference to patient safety in India. And that's why, Ajita always says, looking at sir, we feel we are nothing. We are not doing much. He's such a accomplished leader there, and he is spending this much hours just to understand what we did and encourage us. That itself is a big thing for all of us, and it's a lesson for me also. I feel very humble. Sometimes we think that we are something. We are nothing. So it is a great honor, sir, that you are here. And we would like to invite cohort 3 in your presence. And Vinod, you can tell a quick welcome note to our cohort 3.
Thank you, ma'am. So it's my immense pleasure here to invite all my cohort 3 into ANEI Patient Fellowship. So this moment marks not only the beginning of your transformative journey, but it is also a testament to an unwavering commitment to advancing patient safety in the healthcare. As we look around in the virtual space now here, so you can see the diverse locations and the gatherings of the individuals who share a common passion, nothing but patient safety. A passion for making a difference in healthcare setting. So each one of you brings a unique set of experience, skills, and aspirations, which when combined can create a formidable force for positive change in patient safety. Through this fellowship, you will have an opportunity to learn from the best mentors. As already you heard a few names, and Tanka ma'am is going to continue with us for here. And you're going to collaborate with peers, cohort 1, cohort 2, who share your patients and gain insights that will not only enrich your knowledge, but empowers you to effect a positive change. Remember, this is not a program. It is going to be a collaboration, sharing of your experience, and an impact insight learning by through this continuous effort and collaborative effort that we are going to achieve a greater impact in patient safety. Embrace every challenges. And we also had a lot of challenges. There are a lot of push and pull from Sankama was there to complete few assignments and doing something. So there will be a challenges for you, and take these challenges as an opportunity in disguise. Seek knowledge relentlessly, become knowledgeable in the campus of that guides us on the path of excellence. And most importantly, all my cohort 3 members, as you embark on this journey, know that you are not alone. We are here, cohort 1, cohort 2. People are here to help you out in any extension how it's required and when and where it is required. So on behalf of ANEI Patient Safety Fellowship, I extend my warm welcome to all cohort 3 participants. Together, we will create a safer, more compassionate healthcare which drives towards patient safety. Thank you so much.
Thank you, Vinod. Thank you very much. And, you can see all the, cohort 3 fellows also on the screen. And really, I would like to request Dr. Michael to tell us that you are still with us and we can continue this journey further, so that they all, cohort 2 and cohort 3, cohort 2 will pass out next year and cohort 3 will continue the journey. So we would like to hear from you, sir, how we are doing and are we worthy enough to continue the collaboration with your organization?
Well, thank him and Captain Ajitha. You have such a great program here. I mean, I've just been in awe this last few hours listening to these stellar presentations, and you picked key problems in healthcare. You didn't look for something small. You tackled the big ones that we can make a change for millions of patients if we could get the world to institute the programs that you just talked about over the last hour or so. I think you can all be very, very proud of what you're doing. I'm very honored to be just a small part of what you're doing because it's excellent. It really is excellent. And as you join the Patient Safety Army, you're going in as generals. You're the front, you're the brains behind it all. You've got it all. And I think you can feel confident that you can move mountains. You'll be able to make a difference in whatever healthcare setting you're working, because this program has been so powerful. I mean, every one of those presentations was first class. If I had to pick a winner, it would be impossible because they each were stellar in the area that they approached, the way they approached it, and they showed the results that they had got in place from the study that they did. And that makes a difference. And it makes a difference on the toughest problems that we have in healthcare. So I hope we can continue this relationship for a long time because it's exhilarating to me. It really is. You guys are the best. I'm learning from it. Every minute there today, I've been learning from it this evening. And it's inspiring me to go back to our program and to make a bigger difference. So I look forward to seeing how you develop more in the future, because you're the leaders. You really are. And you're going to make a big change in India or wherever else in the world you all get to. I hear somebody's gone to the UK, somebody's in the Gulf States. You'll make a difference there too. So I think you can just feel very confident that you understand the problem, you've learned how to make changes, you will make changes and you'll continue to make changes. And that's what our patients need. And remember, it's the patients that matter. That's why we're all here, is to take great care of our patients and make it a great experience for them. And I have no doubt that's what you will be doing. So thank you so much for the association. This has just been exhilarating for me and a great honor. Thank you. Thank you, Thankum. Thank you, Ajitha, and thank you all so much.
Thank you. Thank you so much, Dr. Michael. And I would request our president, ANEI president, to accept this offer and seal this collaboration so that the cohort 2 and 3, they know they have work to do.
But they will do it.
And that's what I am sitting there to make sure that they do it. Yeah. So it's a team effort, because if they don't respond to the guidance and whatever, path we can show them, if they don't respond, there'll be no result. So I'm very happy that all the cohort participants so far had been, forthcoming when difficult time came, and when they were asked to redo things, go back and, revisit, they were there. I know they all are doing their own job, and this is on top of that. And most of the meetings are after working hours. They did take time. They came for those meetings, and so I'm very sure that this is going to be a great attraction for being a member of ANEI, because we opened this only for our members. So we are looking forward to great structure, and maybe it will cross borders, hopefully. We are hoping, because once the model is, clear, maybe we can take it to other countries, developing countries, and tell them that maybe this is something that you would like to do for their own patient safety. Thank you so much.
Absolutely.
The seed was
Absolutely.
sown in PSMF.
Well, thank you.
I got that roadmap once I came to know about PSMF, and you were so forthcoming. I mean, you did not hold on and say that, first let's see what will happen. So the blessings came in quite fast, and we are trying to rise up to the occasion and make us more.
You're leading us. Thank you so much.
Thank you. Ajitha.
Thank you so much, Dr. Michael. I'm lost for words actually to be beside you on the screen to address everybody, and the contribution and credibility what you bring to us by this program, being part of this program, is enormous. And this is testimony to your commitment, and I'm very happy that we have role model to present to the youngsters. Because despite all your busy schedule, you've been spending so much time with us, and you had been with us through this journey, and that is testimony to your commitment. And we need to see people doing it, to be telling our younger ones to there are people like this to follow, and it is possible. And not only that, you will tell what you don't have and keep complaining about. This is why we don't have patient safety. We always, in our Indian culture, the safety culture and mindset hasn't yet settled in. It is in the beginning stage. We still blame our people, punish our people for when something goes wrong with the patient or with anything in the healthcare system. And we are at a very rudimentary stage, I must say, in most of the hospitals. And India is a very large country with a lot of population and a lot of patients thereby. And whatever we do today, I am sure is going to impact the healthcare in our country at a very, very large extent. And just wanted to let you know that we have just started before tomorrow's patient safety conference. We started on a mission to educate the nursing students in this country on international patient safety goals. And it has reached thousands of students in the last 2 weeks, and we will be continuing with that for the rest of the year. So we have just begun, and there is no looking back. And I would expect all the patient safety fellows to become, resource persons for that, and many more people to join, so that we can take this message of, how do we safeguard our patients? How we can be instrumental in safeguarding other fellow healthcare workers while delivering healthcare across the country. And we have huge population of healthcare workers as well, and they badly need us, the way we work and the way we reach out to them. And this is a call for action to every healthcare worker in our country. And thank you so much, sir, to be with us and to motivate us and show us the way. Thank you so much.
Thank you.
I mute and then I forget I'm muted. So thank you so much. And thankfully, we are able to wrap up a little early. So sir is free and we are also going to go home, but miles to go before I sleep. Right. So welcome to cohort 3 and cohort 2. We continue. We will meet very soon, sometime in October. Cohort 3 will be invited to meet your mentors and then map the journey forward. So there is work to do. So for the time being, a very warm welcome to cohort 3. I've got, I'll just put it on gallery. So I asked all the cohort 3 to be on the, screen. So we can take a screenshot for all. I mean, all cohort, please come. I cannot be calling out. Please, all those who are present, please be here. Everyone, thank you. So I'm just going to take screenshot. So we should be able to share that on our Facebook, and I'll share the photo with the sir also. And sir, thank you so much. And thank you everyone for joining. I hope cohort 3 is suitably excited and suitably worried how the journey is going to be. So I like to be very candid, suitably excited and suitably worried, because it's not going to come easy, because we may have to learn new things. And I promised Dr. Michael one thing, that this cohort 3 is going to deep dive into their documents. So that is definitely an action plan. There are more than enough, evidence-based practices put out by Patient Safety Movement Foundation. We don't have enough in India. So we will definitely look into this and see that what do we make of it. Okay. So we are going to multiply the outcome from the patient safety fellows, because there is decent amount of work that goes in, and you give it back to patients and back to nurses and nursing students, because most of the things that we do get recorded. It's available on the YouTube. So maybe you would like to go and look at ANEI's YouTubes, what all things are available also, because it's important. Intent is good. That's the place to start. But then action is very critical. Having only intent does not work, right? So we will move together with intent to convert the intent into action, and to make Dr. Michael feel more proud that we are doing more work and we are impacting more lives. And one thing, Dr. Michael, in his speeches, he's invited all over the place, is that when you talk about patient safety, there is also health worker safety. Both needs to be balanced. And that's also something that we should look at. That's what Ajita was alluding to. The culture needs to change. When you champion patient safety, you don't, put the nurse under the hammer. That's why the human factors come in place. And that is one part of the WHO patient safety curriculum that is least understood by most of the leaders. So there is need to, champion that cause and talk more about it. So we'll come up with some creative, innovative ideas that you learn and others also learn. So are we ready? That's my signature action for everything. Are we ready? Okay, if we are ready, we are all set to go. And cohort 2, some of you have volunteered to stay back. Cohort 1, sorry. Cohort 1 have volunteered to stay back and mentor. So thank you. So we will talk about all that in our next meeting. So once again, thank you so much, Dr. Michael, for being here and spending this much, almost 2 hours and plus with us. And we are so honored. Thank you very much. And we will keep you posted on what is happening. And by the way, Dr. Michael has already written about speaking in ANEI's conference in his newsletter. If all of you have subscribed for Patient Safety Movement Foundation newsletter, if you have not, please subscribe. And I hope that he will next time write about the ANEI Patient Safety Fellowship program. Now that you have witnessed some of it, it'll be great motivator for all of us. Thank you, sir. Sir, can you hear us?
I can hear you. Yeah.
Yeah,
Yes.
okay.
Can you hear me? Okay.
Yeah,
Thank
yeah.
you.
I
Thank you so
thought
much.
we
Absolutely.
lost
Yes.
you. Thank you. So as I was telling, we look forward to you for writing about our fellowship program in your newsletter sometime, and it'll be a great motivator for us.
Absolutely.
And that as
Yep.
a clue to spread this more far and wide. Yeah.
Mhm.
Thank you.
That's what we will do. Thank you so much.
Thank you. Thank you, Captain Ajita. Thank you, everyone. Thank you for being here and wish you all the best. And cohort 2 journey continues for sure. Cohort 1, thank you for volunteering to travel. And let's have a great time saving more lives and making nurses' life better. Thank you and good night and take care. Bye-bye.
Bye.
Thank you. Thank you.
Bye, ma'am. Thank you so much. Bye, everyone.
Thank you. Thank you, ma'am.
Thank you, ma'am. Bye, ma'am.
Thank you, ma'am.
Thank you, Dr.
Thank you, ma'am. Bye, ma'am.
Thank you. Thank you.
Thank you, ma'am.
Thank you so much.
Thank you, sir.
Thank you,
Thank
sir.
you.
Bye, bye.
Thank you, sir. Have a nice day.
Thank you.
everyone.
So I am taking a screenshot. Bye-bye. Bye-bye, everyone. Now I need to go and look at what is going to happen tomorrow.
Okay, ma'am. Take care, ma'am. Take rest.
See you tomorrow.
Bye, ma'am. Good night.
Bye, ma'am. Bye.
Bye.
Good night.
Bye.